Good evening, everybody. It is indeed great honor for me on behalf of Sudanese Surgical Club to introduce Mr. Mohamed Nasreldin in this new online platform, Learning General Surgery. Mr. Mohamed Nasreldin is consultant of general and laparoscopic surgeon. He did his MD in general surgery in Sudan, membership of Royal College of Surgeons, London, diploma of minimal access surgery in India. Uh, He's working in Faculty of Medicine, University of Gezira. You are highly welcome, Mr. Mohamed Nasreldin, to join this for Sudanese Surgical Club. Now you can start.
Right. Good evening, everybody. Hello. Um, I would like to thank Dr. Muhammad and his colleagues for inviting me to join this group. I'm so pleased to be with you today to present our work here in our center and our hospital, the Badani Teaching Hospital. This is one of this topic actually I meant by it to reflect one of our efforts in doing complex surgeries here in Medari Teaching Hospital in our unit. And actually, it is actually a good chance for training for the registrars. So I will try to highlight about this gastric GIST by presenting this case. These are three cases actually of huge gastric GISTs, and we will discuss in this presentation the gastric gastrointestinal stromal tumors in general. I will start first of all. I will talk about, we will give some background about the GIST tumors, and then we will present those three cases, and finally we'll discuss gastrointestinal stromal tumors in details. GISTs are soft tissue sarcomas of mesenchymal origin, and they represent 0.1 to 3% of all gut tumors, and they represent also 5% of all sarcomas. As we know, historically, and all teaching, they were considered, in the old teaching, they were considered as leiomyomas, benign, and leiomyosarcomas, malignant tumors. But when they studies by microscopic, electron microscopy, and detailed histopathological studies, they discovered that only minority of stromal tumors have the typical features of smooth muscles. They found that they have neural appearance and some are undifferentiated. Also, gastrointestinal intestinal autonomic nerve tumors are now considered as a variant of GIST tumors. We can here find that it has a neural appearance, smooth muscle component, and also sometimes it is an undifferentiated type of tumors, and also it has an autonomic nerve origin. Discovery of immunohistochemical studies with discovery of CD34 expression in many GISTs suggested that they were a specific entity. Gastrointestinal stromal tumors express CD117 in 90% of tumors, just like the interstitial cells of Kajal. GISTs are microscopically classified into three histological subtypes, either either spindle shape, like spindle cells in 70% of cases, epithelioid in 20%, and mixed in 10% of tumors. So they have different entities and shape of cells: spindle, epithelioid, and mixed tumors. Mixed uh, spindle and epithelioid tumor. Uh, Generally speaking, GIST tumor are underdiagnosed because they discovered actually incidentally when people do OGD or discovered accidentally CT scans or MRIs or sometimes intraoperatively also. The estimated annual incidence is around 15 per million, and they found that there are 900 new cases in UK. When assessing the prognosis, the size, organ of origin, symptoms at time of diagnosis, and mitotic activity are the most important factors. لما نتكلم عن prognosis, when we are talking about prognosis, the size, the organ of origin, symptoms at time of diagnosis, and mitotic activity are the most important factors. And we will talk about the prognosis later in our discussion. This table represents the risk of uh, the gastrointestinal tumors. So, very low risk is in those tumors which their size is less than 2 centimeters, and also their mitotic count less than 5/50 high power field, and low risk 2 to 5 centimeters, less than 5/50 high power field. Intermediate risk less than 5 centimeters, 6 to 10/50 high power field, or here we find more length, 5 to 10 centimeters, but still the mitotic count is less than 5/50 high power field. And the high risk, those more than 5 centimeters and more than 5/50 high power field mitotic count, or more than 10 centimeters with any mitotic rate, and any size more than 10/50 high power field mitotic count. GIST have slight male predominance, and the median age found in many studies ranging from 58 to 61 years. Here I will present 3 cases actually. Case number 1 is 65 years old male presented to the outpatient clinic department with abdominal swelling of 7 months duration. This is his claim, with only dull aching pain. He experienced dyspepsia, otherwise he was all right. He had no any chronic disease. On examination, he looked distressed. With rapid respiration, he was uncomfortable. Abdominal examination revealed huge visible mass occupying the whole epigastric leftover quadrant and extending down to the area and extending down to the left loin. Liver was not palpable and there was no evidence of ascites. We did full workup for the patient. All investigations were normal, and CT scan abdomen with IV contrast was done for him, and it revealed heterogeneous mass with areas of necrosis, which was most likely gastric tumor. The patient then prepared for exploratory laparotomy because of his distress. Here, the urgency to go for surgery was because if he was distressed actually. It looked like the mass effect of the tumor itself was pushing on the diaphragm and causing him difficulty in breathing. Through combined left subcostal and extended upper midline incision, the abdomen was opened. There was a mass completely occupying the upper abdomen, pushing the stomach and the liver to the right. The greater mental vessels were very much dilated and looked very ugly. It was pushing the transverse mesocolon downwards, but not infiltrating it. The mass was pushing the spleen laterally and adherent to it. The tumor was originating from the great curvature of the stomach. It was dissected and mobilized from the pancreas, the transverse mesocolon, and the diaphragm, but not from the spleen. Sleeve gastrectomy, the splenectomy was done. The tumor was 30 centimeters in its longest diameter, and its weight was 11 kilograms. Unfortunately, the operation was not, there was no photos from the operation, but this is the tumor. And also in this image or picture, the part of the stomach is on the other side of the tumor, but it's a huge tumor, 30 centimeters in its length, and it weighs around 11 kilograms. This is a patient after 10 days or more. He did well, and he's now receiving, he's following up with the oncologist, and he received imitamine. Case 2, the second case, 62 years old male presented to the emergency room with abdominal swelling for 8 months, which became painful on the last week. The pain was continuous and relieved only by use of analgesics. He has no dyspepsia or vomiting. He is not known to have any chronic diseases. On clinical evaluation, he was wasted, not pale, and in pain. He was in pain. Vitally, he was stable. There was tender, irregular mass on palpation in the left upper quadrant and the gastric area. Patient was admitted. Measures were taken to improve his general condition. Investigated thoroughly, and all were normal. CT abdomen with IV contrast was made and showed huge heterogeneous upper abdominal as with central necrosis and cyst formation. And plan of laparotomy was made. And plan of laparotomy here, because of this, it was an urgent surgery. It's not emergency, top emergency. And the plan made because of this pain, and it was from the CT scan obvious that there is some sort of necrosis, central necrosis, and it could be bleeding also, because we gave him blood even before surgery. So it was an urgent surgery, and we operated on him. The tumor, the findings were the tumor was rising from the greater curvature of the stomach, infiltrating diaphragm, spleen, and the transverse mesocolon. Sleeve gastrectomy with splenectomy and resection of transverse colon was done with primary anastomosis. Postoperative period was uneventful. The third case, the no photos. There were no photos from this patient. The third was a 75 years old male referred to our unit. He was complaining of abdominal distension, loss of weight, and generalized fatigability. Clinically, he was pale, wasted, and not jaundiced. Vitally, he was stable. He had huge visible abdominal mass in the upper abdomen and extending to the left upper quadrant and left loin. Investigations revealed very low hemoglobin. CT abdomen showed huge heterogeneous mass related to the stomach with evidence of central necrosis. This man, he was admitted with us for more than 7 days, received blood, and we did him actually the CT scan and a true cut needle biopsy, ultrasound guided. The result was gastric GIST. This is a photo of the patient. You can notice here the huge mass occupying almost the whole upper abdomen the gastric right upper quadrant, left upper quadrant, and down even to the left iliac fossa. And this is intraoperatively. You can notice here the small bowel is pushed here in the right iliac fossa. We found that the liver and the stomach was in the right upper quadrant, and it was actually the stomach is pushed that way. And this is the specimen after we did him resection. We operated on him, and we did here wedge resection only because, amazingly, this huge tumor, its base was very small, and it is related only to the body of the stomach, and the base is very small, and we could manage to resect the tumor with actually wedge resection of the stomach, and the result was actually free margin regarding the stomach, and also the stomach was quite normal. The rest of the stomach, apart from the area where the tumor is originating or was originating, looked very benign and very normal. The presentation generally of these three patients was with mass effect, huge mass with its effect. Either the first one was which caused him distress, and I think it was the decision of doing him surgery was urgent because of this. He was distressed, and the second is actually because of low hemoglobin, or the second because of pain. He presented with pain, and the third because of his low hemoglobin and loss of weight and fatigability, and it looked like we can call it the generalized and effect of the tumor. Here we can discuss generally the gastrointestinal stromal tumors. In general, we can talk about the presentation symptoms are non-specific. Generally speaking, we can talk about non-specific symptoms of tumors, depend on the size and the site of the tumor. Is that if we talk about the gastrointestinal stromal tumors in the stomach or the cardia of the stomach, esophagus, or the duodenum, we can tell that the size and site of the tumor can dictate the symptoms that might he may present with the patient with gastrointestinal stromal tumors. Small GIST less than 2 centimeters are generally asymptomatic and found incidentally during OGD or CT scan or MRIs. Also reported that fever, night sweats, and weight loss are actually known symptoms in patients with gastrointestinal stromal tumors. Abdominal mass and discomfort also, as we saw in our patients, they are clinically silent till they attain large size, bleed, and rupture. And this is one of its, these are presentations that the abdominal mass can cause by bleeding and rupture intraperitoneally. Anatomical sites of GIST, generally, stomach. Most of the gastrointestinal stromal tumors are found in the stomach, in 60 to 70%, and then the small intestine, in 20 to 30%, Others, esophagus, mesentery, omentum, colon, and rectum are only 10%. Symptoms of GIST at time of diagnosis are abdominal pain in 20 to 50%, GI bleeding in 50% of patients, GIT obstruction in 10 to 30%, and in 20% they are asymptomatic, especially those small tumors. How to diagnose those patients with gastrointestinal stomach tumors, especially gastric? The standard approach to tumors 2 centimeters in size is biopsy and excision. We can talk here about incidental finding for those less than 2 centimeters or even 2 centimeters and above. But if we encountered one tumor with more than 2 centimeters, it is better to take biopsy or to excise generally, because they are associated with a higher risk of progression if confirmed as GIST. And as we will discuss in endoscopic ultrasound, you can talk about this. If there is an abdominal nodule not amenable to endoscopic assessment, laparoscopic laparotomic excision is the standard approach. Laparoscopic or through laparotomy, we can excise these small tumors or nodules. And if there is a mass, especially if surgery is likely to be a multivisceral resection like those of which we presented, multiple core needle biopsies are the standard approach, because they should be obtained through because those, as I told, if there is a mass, especially if the multivisceral resection is expected, multiple core needle biopsies are the standard approach. Why? Because you can plan your surgery accordingly. If you are going to go in and resect, like what we did, part of the large bowel, you are going to remove the spleen, it will be very difficult surgery, and it needs to be, actually, the patient needs to be prepared well before surgery. So the plan of surgery depends mainly on these multiple core biopsies. These multiple core biopsies should be obtained through endoscopic ultrasound guidance or through ultrasound computed tomography guidance as a percutaneous approach. This may allow the surgeon to plan the best approach according to the histological diagnosis and avoid surgery for disease which might not benefit. Here, the differential diagnosis of these huge tumors in the upper abdomen and left upper quadrant, mainly like lymphomas, mesenteric fibromatosis, germ cell tumors, especially germ cell tumors in patients with less than 40 years, and the non-seromatous tumors are one of the differential diagnoses, and we have to do these 4 biopsies to exclude or to confirm the diagnosis: lymphomas, mesenteric fibromatosis, and also unnecessary surgery or unplanned surgery for adrenal gland tumors, which they can attain huge mass in this area, and also sarcomas from the mesentery, greater omentum, like some liposarcomas sometimes. If a patient presents with obvious metastatic disease, a biopsy of the metastatic focus is sufficient, and the patient usually doesn't require laparotomy for diagnostic purposes. Fortunately, the 3 patients we operated on, they don't have, or they didn't have any, they don't have actually any metastasis to the liver or to the peritoneal cavity. So we hope that they benefited from that resection. Two of them, the resection was actually R0 resection with free margins macroscopically and microscopically. The third, which we resected the transverse colon and we removed the spleen, that was actually, it was adherent to the diaphragm. We resected part of the diaphragm, but we think, and the result of histopathology, talking about a very near margin, actually affected margin of the resection. It looks like R1. But I think because of his presentation as an acute abdomen, what we did for him was good, and hopefully he will benefit from having adjuvant imatinib postoperatively. Here we can talk about imaging for these patients with, generally speaking, with gastrointestinal stromal tumors for from gastric origin. If they discovered that through the OGD that there is actually a submucosal bulge or feature of tumor submucosally. The first important tool of investigation is to do the patient endoscopic ultrasound, endoluminal ultrasound, and with this ultrasound you can tell about the nature of the tumor. Mostly these mesenchymal tumors are found in the second layer, which is the muscularis mucosae or the muscularis propria, the fourth layer. If it is like this one, if it is actually smooth, regular margin, homogeneous, like this one on the right, it looks like a benign one. And if it is actually more or less heterogeneous with irregular margins and irregular extensions, it can give you a clue that this tumor is of malignant behavior. And also through this, we can do, or the endoscopist can do a fine needle aspiration for this tumor, and it can give in 97% of patients sensitive. It is sensitive in 97% of cases. So it is very important in patients who are discovered through the OGD that they have these submucosal bulges. Here there is something which is very important. You have to combine the transabdominal ultrasound just to exclude that these indentations are not due to spleen or sometimes liver or any organ from outside. This is very important. The second important one is to do, if generally speaking, these type of tumors are exophytic. They have the tendency to protrude outside the lumen and outside the original organ. So the CT scan here is very important and crucial. Appearances vary with size and location. Typically, the mass is of soft tissue density with central areas of lower density when necrosis is present. Because of this huge size and because of failure of blood supply to the core, to the center of the tumor, failure of angiogenesis. This necrosis will take place, and that occasion it appears as fluid levels. As the tumor are often ossifitic, it can be difficult to delineate them on CT if the stomach is distended with burial. Though the non-enhancing central necrotic area may be helpful. Can tell you that this is a tumor. A deep crescent-shaped ulceration demonstrating an internal air fluid level may be referred to as Torsielli Bernoulli sign. This is the sign. I'll show you. This is the sign. We can. This is the tumor. I don't know. This is the tumor, and this is the sign. It's actually air fluid level within the tumor itself. Enhancement is typically peripheral because there is central necrosis, and calcification is not common, only in 3% of cases. Metastasis, distant peritoneal, omental, or direct invasion into adjacent organs may be seen in more aggressive lesions, but lymph node enlargement is not a feature. And this is very important because it has a surgical operative implication. These are photos for MRI. MRI will not give anything more than that given by the CT scan, but it may add more information on infiltration of the tumor to the adjacent structures or its relation to the adjacent structures. On the right, this is a PET scan. It is very important for follow-up after giving imatinib. Imatinib as a new adjuvant or as an adjuvant therapy for those patients with GIST tumors. How do we treat those patients? Generally speaking, a wide local resection of micro and macroscopically free margins, R0, is recommended. Function to be preserved, but not at the expense of R0. And here it is very important. The stomach, we can take the stomach totally, total gastrectomy, subtotal gastrectomy, partial, and we can do even in some patients, like what we did in our 3 cases, sleeve gastrectomy in 2 patients and wedge resection in 1 patient. All are actually, this is decided by the surgeon himself, I think, and according to the extent of the tumor and to the involvement and the situation intraoperatively. This is to be decided. So function to be preserved, yes, but not at the expense of R0. This may involve total, subtotal, partial, wedge, and sleeve gastrectomy. Extended lymphadenectomy is not recommended, and this is what actually we said, because it doesn't have any tendency to metastasize to the groups of lymph nodes around. Direct invasion for the adjacent structures occurs in 10 to 15% of cases. The resection should include these structures. If they are invaded, the resections should include them. Endoscopic resection in small ones is not recommended. Laproscopic resection in certain conditions. In small tumors, we can use laparoscopy, but laparoscopic resection must follow the guidelines of the conditions that of the oncological resection. We have to follow the oncological resection. So laparoscopy is not very much recommended in resecting these types of tumors, especially those huge tumors. But some researchers and surgeons, they recommend laparoscopy just in patients with huge tumors to do some sort of exploratory laparoscopy or laparoscopic exploration for the peritoneal cavity. If there are seedlings and involvement of the peritoneal cavity, the greater momentum, or to look for the involvement of the adjacent structures to plan the laparotomy then. So this is one of its benefits, the laparoscopy. But laparoscopic resection of small tumors must follow the oncological conditions. Involved margins or rupture of the tumor carries poor survival. This is R1 resection with involved margins. It actually cause or the patient, his condition carries a very poor survival. And rupture of the tumor before surgery or after or during surgery also make it worse. Condition will become very poor, of poor survival and prognosis. All right, the use of imatinib mesylate, which is a receptor tyrosine kinase inhibitor, is widely now used for treatment of gastrointestinal stromal tumors as an adjuvant treatment for 3 years after resection. It is known to be associated with a relapse-free survival. It is recommended with a dose of 400 milligram, and imatinib can be used as new adjuvant, especially on those patients with metastases and also for those patients with liver metastasis and peritoneal metastasis. It is used for those patients with metastatic disease. It increased the survival rate of those patients with METs and unresectable tumors to 50% in 5 years. Before introducing imatinib into the treatment of gastrointestinal stromal tumors, the survival rate is 20% in 1 year for those patients with metastatic gastrointestinal tumors. Using imatinib for those patients increase the survival rate to 50% in 5 years, which is very good. Side effects of this imatinib is tumor hemorrhage, and it takes place in 20% of patients. How to follow those patients up after surgery? Prognostic factors are the mitotic rate, tumor size, and tumor site. Gastric GIST have a better prognosis than small bowel or rectal diseases generally. And tumor rupture is an additional adverse prognostic factor and should be recorded regardless of whether it took place before or during surgery. Staging procedures consider that most relapses affect the peritoneum and the liver. Most of the relapses are due to metastasis to the peritoneum and the liver. Contrast enhanced abdominal and pelvic CT scan is the investigation of choice for staging and follow-up. To do them for follow-up. High-risk patients undergo a routine follow-up with an abdominal CT scan or MRI every 3 to 6 months for 3 years during adjuvant therapy. During giving the adjuvant therapy, which is given for 3 years, you have to do CT scan in 3 to 6 months. In 3 to 6 months for 3 years. There is no consensus on this follow-up plans. This is actually from the UK guidelines for gastrointestinal stromal tumors, tumor management, which is recommended. These are their guidelines. Unless contraindicated, then on cessation of adjuvant therapy every 3 months for 2 years, and then every 6 months until 5 years from stopping adjuvant therapy, and then annually for an additional 5 years. This will go for more than 10 years, actually. For low-risk tumors, the usefulness of routine follow-up is not known. It's not useful for those of low risk. If selected, this may be carried out with abdominal CT scan or MRI every 6 to 12 months for 5 years. And those with very low risk, this probably do not require routine follow-up. So for low risk tumors, if selected those patients for follow-up, it will be by CT scan or MRI for every 6 to 12 months for 5 years. Very low risk, they don't need to be followed, actually. And those who are actually their tumors are less than 2 centimeters. In the management, less than 2 centimeters in UK, they do not actually resect these tumors. They just follow the patients with 6 monthly OGD for 2 or 3 years, and if not actually increasing in size, they do it annually, this OGD, and they do not resect tumors less than 2 centimeters. Actually, I'm now finishing my presentation, but I think there are messages from our operations or our management, surgical management and postoperative management for those patients with huge gastric GIST tumors, especially operative ones. Despite that, those tumors are enormous and they're very big. The resection, yes, it was difficult, but it was possible. And resection of these tumors and of all these tumors is the most important or the gold standard for their cure and treatment. So the resection is possible. We are using this golf stick incision, or especially on those tumors on the left side, because dissecting in the area of the diaphragm, the spleen, and the kidney below, and the retroperitoneum, and the adrenal gland must be under vision, because it has actually the blood vessels, as I mentioned when I'm presenting these cases, the blood vessels are very much dilated, and you don't know if you dissected blindly at that area what will happen. So this type of incision is mandatory on those patients. Fortunately, we didn't encounter any tumor on the right side. I think it will be a little bit difficult because of the complexity of the structures, hilum of the liver, and the area of head of the pancreas and other areas. Fortunately, we are dissecting only on the left side. In the 3 patients, taking them out and dissecting them from the pancreas was not difficult. There is a clear margin. I don't know whether this tumor is not invading the posterior parietal peritoneum for one reason or another, but it was not actually, despite this huge mass, and also in the second case, it was infiltrating actually the mesocolon, but what was not actually infiltrating the posterior peritoneum, parietal peritoneum. So dissection from the pancreas was not difficult at all. And block resection is very important. So don't hesitate to remove the spleen, the mesocolon, or and the transverse colon with the tumor. It's not difficult, and yes, it carries morbidity, and it makes things difficult for the patient, but it is necessary if you are ready technically and uh, with the support postoperatively of ICU and high dependence unit at least. We are doing it actually in Wad Madani without any ICU facility, but we actually make our own high dependence unit, and we follow our patients for 24 hours or something like this, and then we take them to the common ward, and they are doing well. Um, and this is not because of yes, we have difficulty here, especially these days with the ICU beds because of the COVID-19 and the actually lack of resources which we are facing in our hospitals, not here in Sudan only or Madani, but all over the world. So I think this is actually also one experience that you can do it with the local resources, and, and hopefully patients will benefit from these extended resections. Um, Thank you very much. I'm so pleased to meet you, as I said, and I'm ready to listen. This is actually a perspective. This is from a general surgeon point of view. This is my experience. I'm not a GIT surgeon. I hope and know that there are GIT surgeons who can add to this experience and who can tell us more about the gastrointestinal stomach or gastric gastrointestinal stromal tumors and their experience. Thank you very much.
Thank you very much, Mr. Mohamed Nasreldin, for this very nice and informative presentation about your own experience in gastric stromal tumor, guest tumor. Highly welcome our mentor in Sudanese Surgical Club, Professor Rashid Ahmed Abdullah, Professor Sulaiman Hussein, as well as our colleagues, surgical residents. Please, anyone have any comment or any question or any queries, unmute yourself and ask directly. You are welcome, Professor Rashid, Professor Sulaiman.
Hello. Assalamu alaikum.
Alaikum.
Mohammed, thank you very much for very good experience and very elegant presentation.
Thank you.
And I think you covered most of the clinical and surgical aspects of GIST tumors. I think we started for the last, I think the last 10 years, the last decade, it's becoming rather common, the term GIST tumors. And this is the old term, it replaced the old term of what we used to call the leiomyomas and leiomyosarcoma of the stomach. And thanks to the development in histopathology and immunohistochemistry that brings this term to the surface, and it taught a lot about the natural history of the disease. As you rightly said, the common thing is that they present in our country because of they present with huge abdominal masses. And most of the time they have been wandering around for some time. And usually, like other tumors in this country, they present late. Just one practical aspect, most of those patients initially, they have an ultrasound, they have a CT scan, and usually you have to do an endoscopy to exclude luminal gastric carcinomas. And the typical appearance usually in the endoscopy, which nobody will miss, you see a submucosal bulge, a huge submucosal bulge with a puncture. And the only thing which you shouldn't do is to take a biopsy through the puncture. If you take an endoscopic biopsy through the punctum, usually they bleed heavily. And we have seen many patients who bled in the endoscopy department. They They lost almost 2 liters of blood or so through just a small hole in the tumor. And this punctum actually is just the site of necrosis of the tumor, but there is usually a huge submucosal vessel underneath. So the message that if you have seen a huge submucosal swelling in the bulging the stomach with a punctum, please don't biopsy through the punctum. It usually bleeds and it bleeds heavily, and it will not give you any clue to the diagnosis. The other point is that most of those huge masses, when you take a true cut biopsy, it is an undifferentiated tumor, which you cannot differentiate it from other types of sarcomas. And recently, and I think that we started using immunohistochemistry, and it is very, very much diagnostic of GIST, differentiating from other sarcomas and other lymphomas. So, and I think the natural history of the disease is different. Probably the surgical plan will change. So if you find that is an undifferentiated tumor, and it's very difficult to confirm against immunohistochemistry, and the tumor markers are available now for this tumor in most of the histopathology labs. The other point is that I think that what revolutionized the management of GIST is the imipetinib. The chemotherapy which is used, we found it very effective in using it as a new adjuvant for big masses, or as Mohamed said, it for metastasis. But even for a down stage, most of those masses, and they can operate comfortably after 3 months of neoadjuvant treatment. And then as an adjuvant, it is a must in most of those tumors, unless you said, Mohamed, for small tumors, you might not need, but I think that it is the results are very much impressive with 3 years, or extended to now to 5 years for imipetinib as an adjuvant therapy. And the results are good. So I agree with you that sometimes you find a very huge mass, it may put you off from surgery, but you shouldn't deny those patients surgery. Most of the time, those are resectable tumors. And most of the time you may end up with just a wedge resection of the stomach. As you rightly said, that the base of the tumor is very narrow, and usually it is a cuff of the stomach, it is not all the stomach. So rarely you need to do a partial or a total gastrectomy on such patient unless it's a very huge tumor involving most of the stomach. So the size of the tumor sometimes is frightening. But when you go in, most of the time, you find that you can do a lot and you can resect the tumor. Rarely you may need to do, as you write, in block resection with the colon or with the adjacent organs. And unfortunately, it's the only treatment for those patients. If you deny them surgery, I don't think that the neoadjuvant will solve the tumor. It may downsize it, but it will not remove it. So the surgery, thank you very much, Mohamed, and we really enjoyed your talk, and I hope that you see experience from Gezira coming to these webinars in different aspects. Just another comment, Mohamed. I think يا اخوان في كلام كثير بيقول انه اي عيان داير اي تي يو.
Yes.
ما اعرف have I lost you or I'm still with you?
No.
اي عيان بيفتكر انه نحن we are deferring surgery because there is no ITU bed. يا اخوان most of those patients they don't need postoperative ventilation. All they need يا اخوان is the monitor where you can check the pulse, blood pressure, and respiratory rate, temperature, وده لك هوسمان هميم ورجسترار هميم يحرسوا العيانين. And this is all you need to do. نحن هسه بقينا نلغي عمليات كثيره لان يقول لك ما عندنا اي تي يو. وزي ما قلت يا حمد all you need is a monitor. وزمان ما في مونيتور، انت الهاوس اوفيسر ده بيقعد يحرس العيان يسطر ورقه pulse, blood pressure, temperature, urine output hourly. فهسه دي بقينا ما بنعملها، يبقى في مونيتور، يبقى at least we get a monitor in a room. That is all you need to do. And an oxygen cylinder. فيبقى قصة انه نحن دائما بقينا نتحجج انه ما في اي تي يو بيد، ما في اي تي يو بيد، and we defer major surgeries. Rarely those patients they need ventilation unless they have got a comorbidity of cardiac or COPD or whatever. Yes, they may end with having you need to ventilate them postoperatively. But most of the time you get with just simple non-invasive monitoring for patients, which can be done in just a quiet room or even in the general room. Thank you very much, Mohamed.
Thank you. Thank you.
Anyone have any question? Please unmute yourself and ask the question.
There is one question, Mohammed.
أيوة يا مستر ممكن
Yes,
تجاوب. أيوة.
written يعني من أيمن case 2, why not giving the patient a neoadjuvant therapy before surgery? Because we were compelled actually to operate on him because it was urgent. That patient was actually complaining of severe abdominal pain, and as I said, the surgery exploratory was an exploratory laparoscopy for him, and we came to find that it was actually a greater curvature gastric sinus trauma tumor. Even we didn't do him through cut needle biopsy like the third case. So we had to operate on him at that time because of that severe pain. I think it was because of central necrosis. It was a very huge tumor and infiltrating to the transverse ocular and to the spleen. And it could be also an infarction to the spleen because of these infiltrations. It was actually an urgent surgery. Yes. Any question?
في سؤال يا مستر إنه
What?
when we should start the adjuvant therapy post operative.
I think immediately. Actually, the treatment of those patients, yes, it is. It's not only the role of the surgical team. It is actually a multidisciplinary approach. So you have to consult the oncologist who will start immediately after recovery of the patient with symmetry. And it extends actually, if the recommended dose is 400 milligram for 3 years. And as I said, the follow-up will be from 3 to 6 months of this duration, and it will extend for almost 10 years annually. Follow-up with CT scan for almost 10 years.
Dr. Ahmed Abdurrahman, you are welcome. Please unmute yourself and ask the question. Dr. Ahmed.
السلام عليكم. سلام يا مستر، كيف شاء الله؟ تمام.
الله يخليك.
والله شكرا جزيلا للبرزنتيشن. حقيقة يعني enlight us for more depth in the GIST tumor. السلام عليكم مستر سليمان، بروفيسور رشيد. السلام عليكم. I would like to comment on the neoadjuvant therapy for GIST tumor. As Mr. Suleiman said, usually some patients present with small tumors which is resectable upfront, and there's some tumors that the resection upfront is difficult because of attachment to the important vital structures, or big huge tumors. Then neoadjuvant therapy is a standard now of standard of care. And because imatinib is a standard treatment, the analysis of the mutations is important here, because some types of mutation are less sensitive to imatinib, the regular 400 milligram dose, like exon 9, for example. So if the mutation is exon 9, then we have to increase the dose for 800 milligrams. And the follow-up should be every 6 to 12 months. And usually the follow-up with images. And then you can tell if there is any improvement or not by the density of the tumor. So you see the enhancement of the tumor itself. If it is less dense, then you have the idea that this tumor is responsive, and then you increase the dose, you follow up, you continue with the same dose. But if there is no signs of of any improvement in the CT scan, then you have the option to increase the dose even more. Sometimes some patients do not respond quite nicely to the imatinib, and there is another few drugs still under studies, but they are some like sunitinib show some sort of improvement in the treatment. And as you said, post-operative adjuvant therapy is as well recommended for those patients, and you have to carry on following them up because the recurrence rate as well is not minimum. And some patients that you can't achieve R0 resection, you can accept R1 resection. So the debulk concept is not something that we should ignore. So if you can remove the tumor with you can accept R1 resection, and then you can give them postoperative therapy as well. Shukran jazilan.
Thank you very much, Sir Ahmed. Yes, there is one point here I have to stress on it.
Before, okay,
Yeah,
we welcome
yes.
Professor Rashid. Professor Rashid.
All right.
Can you hear me?
Yes.
Yeah. Thanks, Mohammed. This very interesting cases. Really congratulate you on the 3 cases. And my question is that I have a relative, actually, close relative, and he's over 75, and he presented with this mass. And as you mentioned, it is an exophytic because at endoscopy, the stomach looks normal, except for probably some redness. But a CT scan and a CT biopsy shows that it is tumor with the comorbidity. So that was 3 years ago. So we gave him the imatinib. And the tumor completely disappeared, and he's still, all right. So the question would be that if you give a new adjuvant, imatinib, I think it's very effective. One would probably, if the tumor disappeared, I agree that probably follow up, because I think imatinib is the drug that has got a lot of, now we're using it for advanced anaplastic thyroid carcinoma, and it showed also some effect. So I think imatinib is a drug that has got different, really effect, and probably might reduce, elderly patients having new adjuvant tumor disappeared. I think there will be a big question about operating. But I agree, the ones you had, I think, very well managed, I think, with both surgery and adjuvant imatinib. Thank you.
Thank you very much, Professor Rashid. You are right, but as I mentioned before, yes, those 3 patients were actually presented with mass effect of those huge tumors, actually. The first one was actually distressed, very much distressed because of this huge tumor. And they are very worried. And actually, when we tried, we were actually our aim was to debulk, as said Mr. Ahmed Rahman, just to debulk this tumor. But actually, when we operate on him, we found it possible to resect the tumor, and it was very successful tumor. The second was actually, it was bleeding, and admitted firstly in the medical side because of very low hemoglobin, and then they transferred him to the surgical department.
Well, I totally agree with your indication. There is no question about that.
But I agree with you. If I can wait for the imatinib as a new adjuvant, it will be very safe for the patients, because actually the median age for those patients is 62. So they are most of those patients are old patients with comorbidities. I want just to add one point for and to comment on Mr. Ahmed Abdurrahman. Yes, nowadays they are actually the histopathologists. They are studying the histopathology of the tumor and the immunohistochemistry and the mutational changes that takes place, because the mutational changes can tell whether there will be some response, good response or no response to the imatinib. Like those platelet-derived growth factors mutations, those are actually resistant to imatinib. So if this actually also make us think of, because we don't have this mutational analysis in our labs, at least here in Madrid, and also immunohistochemistry is doubtful. So sometimes we are actually forced to do surgeries for those patients because of their general condition, and mainly the goal is to do them R0 resection. But as you said, we can go out with R1 or sometimes with debulking. And if it is proved to be gastrointestinal stromal tumors, I think the imatinib is very good for reducing the size and for treating the metastases of the residual tumors. Thank you.
We have question from Dr. Mohamed Al-Mujtaba. He asked about, is there any role of radiotherapy?
No, there is no role of radiotherapy or chemotherapy on these tumors at all. There is no role.
Anyone have any question? Please unmute yourself. Dr. Ahmed, you are welcome.
Good evening, everyone. Thank you, our teachers, Mr. Nasreldin, Professor Rashid, and Professor. Are you hear me? Okay?
يا أحمد معلش ممكن ترفع الصوت شوية لأنه ما سامعني.
Okay. Are you hear me? Okay.
Yeah.
Yes.
Okay. Thank you, Professor Rashid. Thank you, Professor Sulaiman. Thank you, Mr. Nasreldin. My question is that, as you mentioned, distribution of gastrointestinal stromal tumor mainly in the stomach, 70%. As we know, there is other lesions, submucosal epithelial lesions. Appearance in endoscopy looks like GIST tumor. So, is there any specific endoscopic ultrasound features that can make us more suspicion to the GIST? Let us to take a biopsy or aspiration biopsy or core biopsy.
All right.
Okay. Is there any specific endoscopic ultrasound features that specify GIST tumor rather than other lesions? Next question is about is there a specific immunohistochemistry investigation that led me to say that about 90 or 100% it is a GIST tumor when I found it. Thank you very much.
All right. Let me start with the second question. It is CD 117. This is diagnostic for GIST tumor, and also CD34. Those are actually, if they are available, they are diagnostic for, and this is an immunohistochemical study. They are diagnostic for GIST tumors. Regarding your question about the endoscopic, yes, you can do fine needle aspiration cytology, as I told. They said before, and it has a 97% sensitivity for diagnosing these tumors.
If no more question, I think for the sake of time, on behalf of Sudanese Surgical Club, we really thank Mr. Mohamed Nasreldin. We are really grateful for the time and effort you took to share your thoughts and experience with the gastrointestinal stromal tumor, and also to reflect the great work done in Madani, Gezira State. I really thank you very much, Mr. Muhammad, and we hope to see you next meeting. Thank you very much.
Thank you very much. Thank you all, Professor Rashid, Professor Suleiman Hussein, Mr. Ahmed Abdurrahman, and all colleagues, the registrars, especially Bakr. And thank you very much, all of you. Thank you very much.
Thank you very much.
Thank you, Muhammad. Allah.
Bye.